Can I have everybody's attention? We can get started here. We have a terrific panel today, so I'll go into that in a second. Let me just do a couple of pieces of housekeeping first. For everybody who's taken this as a 2-credit class, you'll be getting emails tomorrow. It's not tonight from me, but just comments on the first set of 3 reaction papers, just so you've got a little feedback from us as we go through the course of the rest of the semester. Second, for those of you who are working on your 3-credit paper, today is the day to turn in your full thesis statement and outline. And Susan's here if you want to hand in hard copies. Otherwise, send in the emails. So appreciate that. And then third is just a reminder, you should have gotten an email that the class that was originally scheduled for November 4th has been moved to November 5th from 2:30 to 4:30, just due to conflict with our speaker. And then finally, we are on next week with Ambassador Diebold, too, for this same conference. So that's any other housekeeping matters from your end? Well, I'm going to introduce our panel, but we have this is a terrific, this week and next week's session with Ambassador Diebold, a great couple weeks of looking at issues in global health assistance, and we have just a fabulous panel here today. So I'll give you a brief introduction, and then we'll go through. But what we're going to start off with, our first speaker is Ruth Levine, who is a senior fellow with the Center for Global Development. And she's had a number of high-ranking positions in the World Bank and in other organizations looking at global health issues, looking at global health assistance. And she's going to give us an overview for the first 15 minutes or so of key issues in this area and from her perspective. Our second speaker is a former colleague of mine, Dr. Margaret Hamburg, who is senior scientist with the Nuclear Threat Initiative, which is a great name for an organization, but looks at a whole range of issues involving weapons of mass destruction and other threats and health. And she's going to talk to us from her experience there, but also from her experience, which has been vast, as the Assistant Secretary for Planning and Evaluation at HHS and the Commissioner of Health in New York City for many years. And so she brings an incredibly rich perspective from the global, national, and local level for these issues. And then third is Dr. Bernhard, who is the chair of the International Health Department at the School of Nursing and Health Studies and is an integral member of the faculty of the O'Neill Institute for National and Global Health Law. He has many years of experience in working with the World Bank, working in the national government of Germany on health issues. And so thank you for joining us, Bernhard. And then finally, last but hardly least, our senior scholar with the O'Neill Institute, Rudolf, who was an attorney in the consulate office at the World Bank for many years, working on HIV/AIDS issues in particular, but on a range of topics. He's been writing extensively on global health assistance and legal issues relating to that. So this is a fabulous panel that we've got today. So we're going to start off with Ruth, who's going to do an overview, and then invite each of the 3 speakers to say in general. And really, we'll then take our break, and then afterwards open it up to questions. Again, the usual for the students in the first couple rows, we'll have the first few questions be to you, and then open it up to the larger audience. So anyway, I don't want to take up too much more time, but thank you all very much for joining us, and look forward to a great couple hours of discussion.
Thanks very much. It's really a pleasure to be in the conversation, and I'm eager to start it and then get to hear what the other panelists have to say, and then hear your questions as well. So, John, I'll count on you to let me know if I'm droning on a little bit long. People see that reasonably well over there? Oh, yeah, okay. Great. So, I guess before I start, I wanted to do a little pop-up ad for the Center for Global Development. So CGD is a small think tank. We've been around for almost 7 years now, and we do work on how the policies of the U.S. and other wealthy countries affect the prospects for development of poor countries. So that includes development assistance for health, but it also includes a much broader agenda related and unrelated to health. So we look at migration, trade, climate change, debt, and other issues that really link the rich countries with developing countries. So I encourage you to look at our website, and we have a couple of blogs that we try to have an active conversation going. So if anything sparks your interest in the conversation today, please feel free to continue the conversation online. So what I thought I'd talk about today is really just to give a very quick once-over of some of the basics of global health, particularly focused on health conditions. Then I'm going to, again, in a bit of a superficial way, run through 4 key, what I call conundrums or tensions that you'll see and have seen reflected in the global health world and discussions, particularly at the international level. And then I'll talk a little bit about the institutional architecture. So we'll actually end, I think, with the conundrums. So a big message that you should hold in your head is how phenomenally successful the health sector has been over the past 50 years. It's very easy to get fixated on the problems of today and to look at some of the desperate conditions that do affect poor people in poor countries. But the big sort of long-term story is one of tremendous improvement. So what we've seen over the past 50 years is an improvement in life expectancy from 40 to 65 years. A halving of child death rates, and a reduction in the impact of many killer diseases, not just smallpox, but many of the tropical diseases have been greatly reduced in incidence and prevalence. There's a big story about improvements that are due partly to a general increase in economic and social conditions, standard of living, but also to an improvement in access to health services and to the development of new health technologies. Immunization is a clear winner here. The introduction of childhood immunization had tremendous impacts, particularly in low-income countries. But there are problems, and let me just run through a few of them that need to call our attention. One is a near stagnation in improvements in child mortality in some of the poorest countries, particularly in sub-Saharan Africa. So while there have been some recent, in the past year or two, positive signals, for about a decade we've seen essential stagnation in change in child mortality in sub-Saharan Africa, despite the widespread knowledge, really, about very inexpensive, very effective child health, or what's called child survival interventions, whether it's the use of oral rehydration solution to combat dehydration from diarrheal disease, immunization, as I talked about before, vitamin A, supplementation, really very basic health interventions. The child deaths are highly concentrated, as I said, in sub-Saharan Africa and in South Asia. So that's a problem. Second problem, and the one that I'm sure you're most aware of, or I imagine you're most aware of, is the toll of HIV/AIDS in some countries, particularly in sub-Saharan Africa, which have erased many of the gains in life expectancy in the heavily affected countries. And a key point that I want to bring your attention to is that it really is, compared to the 190-some countries in the world, is it really a very small number of countries who are very acutely and intensively affected by the AIDS, high incidence and prevalence of AIDS. And those countries are dramatically affected. Their whole social structure, age distribution, economic prospects are dramatically affected. And we can see that the next generation is going to sort of carry this with them if you look at where incidence is highest, you really see a tremendous toll, particularly among adolescent girls. So out of all people who are in Southern Africa who are HIV positive between the ages of 10 to 24, 3/4 of them are female. A third problem of maybe 4 that I'll talk about is persistently high levels of inequality, health gaps between rich and poor. And what this chart shows is the differentials in immunization coverage, a kind of key indicator of health service coverage in different the world between the richest 20% of the population, and that would be in purple, and the poorest, which is in blue. And you can see pretty much across the board a very consistent pattern. So this ends up being manifested in health outcomes. So for example, in Indonesia, a child born into a poor household is 4 times more likely to die before her 5th birthday than a child born into a wealthier household. And these sorts of differentials are often greatest in the poorest countries. And finally, in terms of sort of problems that are very present and really need to call our attention for the future, is a combination of demographic trends, that is the aging of the population as fertility has declined in many middle and low-income countries. Combination of that with an epidemiologic transition, somewhat away from infectious diseases and toward chronic diseases. And the picture here is of a very young Chinese child smoking, to emphasize the point that this generation of the Chinese population might be all smoking. A majority of Chinese men are smoke relatively heavy amounts, and infections for tobacco-related ailments. It's really a kind of tsunami of chronic disease that's ahead of us, not just in China, but in many parts of the developing world. So that's the kind of background. Long track record of great success, and then really important problems that need to be solved. Now I'm going to turn to why it is that people in rich countries think it's their responsibility, or they have an interest in helping to solve those problems. Sometimes we take it for granted, but it's actually sort of a funny thing to think that we're taking money from our pockets to help in improving the health of people somewhere else, people we're never going to meet, people whose health actually only has a kind of distant relationship to our own well-being. So there are multiple rationales for development assistance that are invoked in different ways. I'm just going to run through a few of them. One, and I think a core one, is around something we might call values. And that is that there's a sort of feeling, an intrinsic value that people place on being generous and being seen as being generous. So this is actually this kind of storyline that you often see associated with all types of assistance, whether it's humanitarian or longer-term development aid. There are clear self-interest arguments. A few of them are diseases know no borders, so if somebody acquires an infectious disease in a poor country through airplane travel and other kinds of interactions, it could affect us. That's certainly present in the story of extensively drug-resistant tuberculosis, for example. Second is goodwill enhances security. If we're seen as being nice to people in other countries, maybe they won't come and bomb us. That's not a very nuanced argument, the way I put it, but that is certainly part of the storyline. And a third is some direct self-interest from those who are providing goods and services that are funded by development assistance through contracts and other forms of procurement. And the third is a little bit vaguer, and I'd say it's around some sense of leadership and responsibility. And this comes through partly in the U.S. and even more Europe, where they have long-term relationships with former colonies. We have to live up to our commitments. We believe in some version of global justice, and with that comes some sense of the need to reduce inequalities between rich and poor. And in Europe, you sometimes hear the kind of narrative of we are part of the problem, particularly around the migration of health workers. So you see in the British press and in aid documents in Britain and elsewhere, we recruit nurses from Ghana to be in our National Health Service, therefore we have an obligation to help mitigate that problem elsewhere. There are a few countries, this gives a sense of who's giving the most. It's a little bit old data, but the most recent I could get in this form. There are a few countries that are the big givers. The U.S., not relative to what it could give, but relative to what others give in terms of dollars. The U.S. is the big provider of development assistance overall and development assistance for health. So about 14%, actually more than that now, of U.S. aid has in the past gone to public health. Now it's actually up to almost 30%. And as you can see, at least at the snapshot when these data are from in 2005, the U.S. was putting in somewhere in the order of $3.5 to $4 billion. It's significantly higher now. Japan is another big provider of development assistance, and then several of the European countries. I don't know if this comes. Can you guys see the yellow line? Okay, well, so somebody's going to tell me what this says. So I'll tell you what the axes are, and then you tell me how you interpret it. So this shows the level of official development assistance for health from the U.S. In billions from 1994 to about 2007, split out by child health is the dark yellow line, population assistance separate from HIV/AIDS is the blue line, and HIV/AIDS is the light yellow line. So what's the story? The story is PEPFAR. So you want to expand on that?
All the money came in right around that time, and they had were able to provide access to those medicines, HIV.
Right. So the only thing that's happened in the past, say, 6 years, in terms of where the dollars go, is that much, much, much more money has gone to HIV/AIDS. Everything else has been flat, and there's actually been some reduction in family planning monies. So that's the story. A lot more money for global health overall, and virtually all of it for HIV/AIDS. And where does the money go within those resources? Right now, the majority of the money goes to purchase products, drugs, outside of HIV/AIDS, vaccines, diagnostics, supplies. It didn't used to be the case. It used to be the case that the largest shares went to technical assistance and infrastructure. Now the largest share goes to drugs. Technical assistance is also a significant piece. I think it's about 25 to 30% now. In-country infrastructure and in-country recurrent expenses to keep health systems running, save for salaries, is also provided through development assistance. So technical assistance is a bit of a term of art, which means generally consulting services, in the U.S. case from U.S.-based consulting firms who actually implement programs in country and or support government staff to implement those programs. So it can be long-term resident advisors who live in country, or most often it's people who travel to the countries for relatively short missions to assist with designing and implementing programs. And in the U.S. case, this isn't true for all donors, but in the U.S. case, there's a provision, the Buy America provision in the Foreign Assistance Act, which requires that goods and services are procured from U.S. suppliers unless there are a few different exceptions under which that doesn't have to hold. But in general, it's what's called tied aid. So you can actually see that if most of the money is going to buy imported drugs and most of the money is going to buy essentially imported services, and another large share is going to buy imported services, there's a huge amount that actually ends up in country supporting implementation of programs literally on the ground. A couple of words about the current international institutions involved in global health. If we'd been doing this slide even, 7 years ago or so, there would be a few boxes. There'd be the UN agencies, there'd be the bilateral donors. Now there are many, many, many players who have emerged from UNAIDS, the only UN entity that's devoted to a single disease, to the Global Fund to Fight AIDS, TB, and Malaria, to Project Red, where you buy a T-shirt at the Gap and a portion of that goes to the Global Fund. Lots of NGOs who have a long track record but have gotten even more into health work in recent years. And then the large supersize Bill and Melinda Gates Foundation, which has actually been a key player in much of the development of global health over the past 5 years or so. So now I'm going to turn very briefly to 4 conundrums. And as I said, these are just sort of tensions that maybe we can have a conversation about and that play out in different ways in the international health dialogue. One is about, should we be spending money today on interventions and activities that we believe can save the lives of people who are most affected by disease and disability today? Or should we take that money and put it as an investment in research and development for technologies that that may bring about even greater health gains in the future? So this shows a sort of contrast between malaria bed nets, interventions that work sort of today and are being widely distributed across regions in Africa. Or should we put the next dollar in research for a malaria vaccine that would potentially reduce or eliminate the need for bed nets in the future? So that's a question that those in the policy community have to grapple with. Another one is, when we're designing programs, do we focus squarely on very specific concrete results, like, for example, in the PEPFAR program, the number of individuals who are put on antiretrovirals when their CD4 count warrants it? Is that the result that we're... Or do we put our money in things like information systems, logistics systems, infrastructure, training health workers, reforming health financing arrangements, building up management capacity, and these other kind of long-term efforts to improve a broad set of health services and public health efforts? This is a very, very active debate. In the recent past, the emphasis has been quite a bit more on quite narrowly defined results. You see that in the Millennium Development Goals and in the structure of the PEPFAR program and others, President's Malaria Initiative as well. There's more recently been a real, I'd say, rhetorical backlash against that and a call for greater spending and attention to systems rather than specific diseases and interventions. The third tension is around global goals, and here we see Bill Gates administering polio vaccine. And I'm quite convinced that the reason donors love polio vaccination is because it's an oral vaccine, and so they can actually be seen giving this life-saving medicine as opposed to using a needle, which other immunizations require. So Bill Gates giving a polio vaccine to a child versus a teaching in Nigeria, where the immunization rate on average is something like 20%, and Nigeria, which is home to a quarter of Africa's children. So, and Nigeria, where there have been outbreaks of polio because of the reluctance of state-level governments to put their whole heart into polio eradication. So there's a lot of tension, actually, between the goals that are established on an international level, like polio eradication, or like universal access to antiretrovirals, and what actually national governments and perhaps the people they purport to represent really want to see in terms of the health priorities. And so again, you see this played out in many ways. Perhaps we can talk about that a little later. One thing that comes out when you're thinking about the international goals versus what national is kind of dynamics that occur in countries. In this slide, bring out a few that are really becoming increasingly prominent. One is the rise of civil society voices. In countries, some of them really resisting external influences and the priority setting that's driven by donors. Second is pressure from domestic economic sectors that are associated with health. And so, for example, I'm working on a project that's looking at the pharmaceutical industry in India. And India, the government of India, has policies that essentially require it to buy most of its drugs and vaccines from Indian manufacturers. Well, there may be good reasons for this, but it can also be a constraint on access to medicines for Indians. And one of the central reasons for having that policy is industrial policy. It's to build up the Indian pharmaceutical industry. So that's playing out. There is growing recognition of the relationship between health and the economy, and this was most visible in China when there's essentially a quarantining of China during the SARS epidemic, and their economic prospects looked pretty dim for a while because of that. And there's a growth of private service delivery, which donors haven't quite figured out how to say. So the last conundrum, and I think my last slide, is inspired by the financial crisis within which we now find ourselves. And that is or at least the challenge of sustaining support for development assistance, whether for health or other things, in the face of really severe pressures on the domestic economy of wealthy countries. And what this shows is some work that a colleague of mine did to look back at what happened during the financial crises in Nordic countries, and he also looked at Japan. And the clear story is that when a banking or other financial crisis hit, among the things that happened in terms of government spending were pretty dramatic declines in overseas development assistance. And we do see this consistently with even more gentle economic downturns, that ODA, official development assistance, tends to be pro-cyclical. That is, when the economy turns south, so do the numbers on development assistance. And in some ways, it's exactly the opposite of what you'd want to see, because development assistance might be thought of as a bit of a safety net, where you'd want to maintain support for vitally needed health services when people are more vulnerable economically. But what you actually see is that the money declines. And you heard that in Joe Biden's remarks during the the vice presidential debate. If you were listening like I was, you heard Joe Biden say that among, actually the only example of something that he suggested would be changed in light of the financial crisis was that the promise to double aid would not be realized as quickly as they'd hoped. Well, development assistance represents a microscopic part of the U.S. budget, so it's not exactly a very effective strategy to save money. But it was interesting that that was the only thing that was called out as a response. So with that, I hope it gives you a sort of 60,000-foot view, and I'll look forward to my colleagues' comments.
That's terrific. You're welcome to talk or sit down.
I think I'll just stay here. Well, thank you, Ruth, for getting us started with that broad look at critical issues and challenges in the global health arena. I'm going to speak from a rather different perspective, hopefully to complement what Ruth and the others will speak about. But first of all, as a public health official, focusing mainly from a public health perspective, meaning looking at how to prevent disease and promote and protect the health of populations rather than focusing on individual care, but also more significantly from the perspective of the intersection of health and security concerns. As was mentioned by John at the beginning of the session, I work for an organization called the Nuclear Threat Initiative, and I'm constantly having to explain myself when I go places because I work on biological threats. Well, the name partly reflects the stubbornness of Ted Turner, who was our primary donor. He had originally, his vision was to create a foundation that's goal would be to eliminate nuclear weapons around the world. And he approached former Senator Sam Nunn, who is renowned in the world of nonproliferation and arms control, and said, would you like to co-chair this foundation with me? And Sam Nunn said, I don't think that the goal of eliminating nuclear weapons is very realistic, or perhaps not even desirable, although interestingly enough, he's since changed his tune. But I'd work with you at this foundation if you addressed weapons of mass destruction more broadly. Had the mission statement read, to reduce the threat of weapons of mass destruction. Mind you, this was pre-9/11, so even that was exotic. Then they approached me to head up the biological arena, and I said, well, I'll for you if you broaden the definition of biological threats and include naturally occurring disease threats as well, because as I look at the problem, there's a continuum of concerns with biological weapons and biological terrorism being at the extreme end. But there's a whole set of concerns that burden both the developing world and the developed world on a day-to-day basis that demand our attention and demand solutions, that in fact there's a considerable amount of overlap between what needs to be done to address the threats of intentionally caused disease through terrorism or warfare and those of naturally occurring disease, primarily thinking about infectious disease threats, although we recognize, as Ruth indicated, that chronic disease, as well as injury and other concerns, represent, in fact, the largest cause of morbidity and mortality or death and injury around the world. But we really, as an organization, in terms of my personal work, have focused mainly on infectious disease threats. But that's the thumbnail of how I come to work on biological issues from a place called the Nuclear Threat. But problems like the one just mentioned by Ruth, SARS, and the looming threat of pandemic flu, I think certainly underscore how Mother Nature is a terrorist, and that we would be ill-prepared if we didn't think more broadly. It also, I think, means that we can use limited resources more effectively if we're thinking about how investments we make can help build infrastructure and capabilities that will enable us to respond to day-to-day needs as well as to months of a catastrophic event. So With that as background, let me just say a few more specific things about some of the kind of work that I've been involved in and some of the kinds of issues that I see as increasingly on our national agenda. First, I should probably acknowledge that the intersection of health and security is a somewhat unstable realm. Many of my colleagues in public health have criticized me for consorting too much with the Department of Defense and the intelligence community and others. And on the security side, I sometimes encounter great disdain for the softness and squishiness of public health concerns. But in fact, health and security are very much linked, and they have been since the beginning of time, and that the issues of how health influences the strength of economies, the ability of resource-poor countries to develop, social stability, political stability, all are very interconnected with health, and you can see that in very different ways. Certainly with SARS, we saw a new recognition of how health intersects with economic security and stability. We also saw how it intersected with political leadership. A number of high-ranked health officials and political leaders lost their jobs in China over how SARS was handled. We know, in fact, that the CDC first emerged in the context, the Centers for Disease Control first emerged in the context of concerns about the safety of troops and their risks for malaria training in the Deep South. So there has been a linkage, but it's not a completely comfortable area, and during the opportunity we have for discussion, we might want to talk more about that. With respect to the issues of infectious disease, and give me the hook. I said that it's a continuum of concerns, and from my perspective, the best defense against both naturally occurring disease and intentionally caused is a robust and global infrastructure for public health and critical health care. That means strengthening disease surveillance around the world so that we can rapidly detect and respond to emerging threats and monitor disease trends at the local, national, and international level. It means strengthening the healthcare system to deliver essential care and to link it into public health so that we can better match what we can learn about disease trends and the burden of disease with the care we actually deliver. It also means investing in science and research so that we have better tools, both in terms of better diagnostics to recognize disease and treat it cheaply and quickly at a local level, and new drugs and vaccines to manage care and control disease, as well as much better utilization of advances in information technology that's now available. For bioterrorism, advances in science, I should also note, do hold a dark side. That is, as we learn more and more about organisms, how they cause disease, and how to manipulate them, essential activities for developing better drugs and vaccines, we also now have the knowledge and tools to create more damaging organisms, should that be our desire. And the truth is that these skills and the equipment needed to undertake these kinds of tasks are increasingly available around the world, increasingly mechanized, increasingly low cost, and we know that people with limited exposure through training in modern day biology, in fact, could undertake some devastating tasks. So a new challenge to us in terms of how to provide responsible stewardship around the globe to the scientific enterprise, which is very much in nature. The last thing I'll say quickly is health diplomacy, an increasingly talked about activity that does link to many of the things Ruth talked about, and certainly links to health and security activities. We do have a remarkable opportunity at present to translate our capacity as a nation, our strengths in medicine, science, and public health into programs around the world. Obviously, health is an intrinsic good, but we can also use health programs, I believe, in ways that will help foster broader foreign policy goals and can help us to do important work that will save lives and prevent disease in areas of great concern, both because of the burden of disease, but also because of the tensions in those areas, the conditions where disease is making life more difficult, and where those conditions may help foster terrorism. And it's also a wonderful opportunity for the United States to put on a much more positive face to the world. We've never been less popular, sadly, than we are today. Perhaps that will change soon, but I think we could use health programs to strengthen our place in the world and to create new partnerships and cooperation for a safer and more peaceful world. Thanks. Sorry, I went too long.
Oh, that's Bernhard, I'm just going to make sure this.
These all the mics are on, and
I don't want to go off.
Yeah, I was listening to Ruth and the conundrums, and to my mind came a couple of events which happened in the last couple of days. A cartoon which I got from a colleague in London, David Molyneux, an email which arrived this afternoon this morning from Navrongo, where we have a student, a meeting which I attended at USAID for the last 1.5 days. So let me go through them in a minute, because they illustrate in a way what we are talking about. The cartoon. Imagine 2 aliens with these bubbly eyes, right? Floating indefinitely in outer space, and there they see planet Earth. Yeah. And one says to the other, look there, only 3 diseases on this planet. Right? TB, malaria, HIV/AIDS. I thought to myself, they must have read the most recent OECD DAC development report on aid in the health sector, because it just came out. And it shows precisely that. It shows that 35% of the overall development assistance in the health sector, 35%, not 20, 35% go for HIV/AIDS, 16% for TB, malaria, and some other infectious diseases. That's 51%. 51%. And the other one is health general, 18%, reproductive health, 10%, basic health services, 21%. So you might wonder whether, if anybody has educational efficiency or so, you might wonder. If someone then looks at the total development assistance for the health sector, that's these wonderful graphs which you just have seen from Ruth. In the 70s, there was about, all in 2006 prices, there was about $1 billion which country-based development assistance was, that was the level of assistance. It went to $3 billion in the 90s, and then it stayed at that level basically until 2000, 3.3 billion. And now it is 8.6 billion. Hallelujah, you would say. That's a fantastic increase. But the question is, where did it go? That is donor assistance. You find a similar trend, for multilateral assistance that goes up as well considerably. to about 4 billion from a level of about 1 billion. So all in all, tremendous increases in donor assistance to the health sector in the last 5 years. The health sector has fared much, much better than any other sector. If you look at the levels of development assistance really across sectors after the Cold War ended, the development reached down, almost to half of it and then slowly recovered, but the health sector as a whole has fared quite well. But the issue which is on the table is, for what do we use this money? Have we created a new institution, the global fund, etc.? So there are distortional issues which one need to look at. Second point. We have several students in Navrongo in northern Ghana, and they have to do research work. And one of them, Rudolf, sent an email today and said, I would like to look at quality of care issues in the hospital in Navrongo, particularly health manpower issues. That hospital, northern Ghana, serves about roughly 650,000 people. There are 4 physicians, 2 of them are Cubans, and so on. If you look at the health manpower situation of the human resource development in the health sector, particularly in the African side, here I focus specifically on Africa. Asia is different, and Latin America is different, but Africa, then the situation is rather shocking. Burkina Faso, for example, Sahelian country, has 3.4 physicians per 100,000 population, 19 or maybe now 21 nurses. So we can go through that. Compare that to Egypt with 220 physicians per 100,000. So tremendous shortage of health manpower. Truly tremendous shortage of health manpower. And then, even worse than that one, 7 out of 10 African countries over the last decade have lost. The ratios have gone down. They haven't increased. Health manpower is decreasing. Now you ask yourself, if you do all these issues on HIV/AIDS, on different diseases, on malaria, who is going to do it? Vacancy rates are 40 to 50% for physicians across the continent. And then you have the carousels that people go from South Africa to New Zealand, and then Nigerian physicians move in, and so on. So you have the dynamic of migration. But bottom line is that there's tremendous health manpower shortages. And the international community has slept through that one. That's really what it is. For 2 decades we have slept through that one. It only came back about 5-6 years ago, 4 years ago. It really came to the overall attention. Why? I do not know. I might be biased because I worked on health manpower issues in my previous life in Cameroon. And I just wanted to share with you Cameroon as an example. Because you will ask yourself, why is that so? Why is there such a shortage of health manpower? Now, Cameroon is a country I've lived in and worked in, and as a deputy provincial medical officer for a large province, and as being in charge of training. In the 80s, the economy went south. They didn't have oil yet in Cameroon. So the problem of structural adjustment, which you have heard, came out. And Cameroon was one of the cases where structural adjustment was prescribed by the bank. And that made sense at the time. But the side effects of that were devastating. Because if you look at the health manpower base, 15 years later, they lost 70%. I repeat it, 70% of their income. But there was mandatory retirement at age 55, no allowances for travel, no allowances for housing. You can go through that, everything, and 2 salary reductions and the devaluation of the franc CFA. So what happens in a country like that? People walk away. They vote with their feet. They walk out of the health sector. So very difficult to find people, and that these lingers on. So real issues which one has to deal with in international health today. Third point. I attended a meeting at USAID about tropical neglected diseases. That is packaging onchocerciasis, river blindness, lymphatic filariasis, elephantiasis, trachoma, etc. together, and for years there was very little funding for these activities, but now in competition with HIV/AIDS, the group to which I belong as well, is trying to muscle in and get a bit of the turf. We were about 100 in the room, and we represented maybe about 40 organizations. WHO was there as well, and USA convened the meeting, and the Gates Foundation was there. And the question which permeated through the room, because USA is going to put $350 million into a program of that nature, and the Gates Foundation is going to put $40 million into it, and the British government has said it will put £60 million into it, and so on. So the story around us, how do we do that? But behind the issue is, how do we organize ourselves? Who takes over the leadership, or do we need a leader? We call that governance. It's a wonderful word for how political processes is. Or how we all on a dance floor move along. With whom do we dance so that we get through it? Something like that. What? Governance. How do we organize ourselves? Extraordinary complicated issues in the international health arena. There are examples in which that has been somewhat achieved, but these are issues which are very pressing these days, because, as Ruth has said, there are many, many new actors which have joined the club. Many NGOs, the research-based pharmaceutical industry with donation programs, you have the traditional donors, WHO has become weaker, and so on. So you look at different actors, and these actors have to organize themselves newly. And the present UN structure with WHO at the helm and normative rules only provides a limited framework in which that. The third point which I wanted to make to illustrate a little bit the issues with Ruth had. Thank you.
Thank you. That was great. Thank you. It's hard to figure out what to say after these three wonderful and very broad presentations. Perhaps I should start with a story that Julian Schweitzer is fond of telling. Julian is the director for HMP, Health, Nutrition and Population, at the World Bank. And when the Minister of Health of Mozambique was just appointed, Julian Schweitzer had a chance to meet with him, and he congratulated the minister on his new appointment as Minister of Health. And no, said the minister. Objects, referring to the obvious problem that he has in coordinating the work of over 100 major organizations in the health sector in a typical developing country. Rwanda did a study on that not long ago, and it found that of all the money that went into assistance to the health sector in the country, only 14% went through the Ministry of Health. Another 12% went to other government ministers. And the rest, over 75%, was done directly by donors in contact with NGOs or through their own organizations in the countries. Now, how, as a Minister of Health, do you ensure policy coherence in a situation like that? How do you make sure that the activities that are going on in the health sector meet your national priorities? In that report, Rwanda states that $46 million went to HIV/AIDS, $1 million went to the integrated program of childhood diseases. Not exactly in line with its own priorities. And then you have, of course, the volatility of the commitments that was referred to in the comments here earlier, especially with the large increase in treatment for HIV and AIDS. This question of sustainability and the requirement on behalf of governments to continue the treatment once people are put on treatment, with the volatility of donor commitments, and as was noted the tendency to reduce assistance when times are tough, just when they should be more needed. It's going to be a major problem. Lead over, who's now with your organization, famously referred to that as to PEPFAR as the first international entitlement program. Like we have Social Security here, AIDS has become an entitlement program internationally. And just like in this country we have difficulty managing entitlement problems, it will be even more difficult for developing countries. Now, to bring all these global considerations down to a more, what I thought might be a more manageable level, I went looking for coordination, as Dr. Liese mentioned, the organization of all these new actors with respect to just one disease, HIV/AIDS. And I looked at what coordination there would be between PEPFAR, the Global Fund, and the World Bank. And I looked at the Paris Declaration on Aid Effectiveness of 2005, which has a number of targets, and I picked out 10 that were relevant for HIV/AIDS. And let's see how well we can make these partners dance together. One, whether aid flows are aligned with national priorities. World Bank funds for HIV/AIDS typically are incorporated in the budget in most countries, contrary to the Global Fund and PEPFAR, which are, their support is typically off budget and therefore much more difficult to align and to account for when you're looking at national priorities. Two, strengthening the capacity of the country by coordinating support for capacity building. The answer is uncertain. PEPFAR often supports capacity building by the Global Fund, and the World Bank provides capacity building for the execution of Global Fund programs. But Global Fund is a financing mechanism, executing agency. But the bank's TA is typically devoted in large part to procurement and to disbursement. And these are typically standalone type of TA exercises. Three, use of the country procurement system. The World Bank very much tries to and does use the national procurement system. The Global Fund used to for national procurements, but is moving to realize a procurement system in most countries. And PEPFAR has its own system. Four, use of the public financial management system. World Bank and the Global Fund, yes, in most countries. PEPFAR uses its own system. Fifth target, avoiding parallel implementation structures. The World Bank and the Global Fund famously used to support separate project implementation units in the countries in the past, although that has changed, and by now I am told more than half of them are used the same or a joint PIU. PEPFAR has its own implementation system. Six, make aid more predictable. World Bank loans and credits typically for 4 or 5 year terms. Global Fund 5 years, but there's a review after 2 years, and they do cut you off or reduce you if you don't meet their the agreed upon targets. PEPFAR, 5-year program, but annual does not improve the ability of countries to ensure sustainability and continuity. The question of tied aid was raised. That's one of the targets of the declaration. The World Bank and the Global Fund fully untied. PEPFAR tied. Use of common arrangements or procedures. The World Bank participates in swaps or sector-wide approaches. It's a disbursement mechanism where the World Bank no longer will fund as it used to, and other projects typically does finance concrete, specific items, but will pool the resources under its loans or credits or grants with the resources of other donors, so that procurement will be much more efficient out of that common pool. Global Fund participates in those only to a very limited extent, and PEPFAR, no pooling. 9. Shared analysis and strategy support. All three pay lip service to this and say, yes, we will provide common support for analysis and one common country strategy, in principle. But when you listen to the countries, there are loud cries of complaints about the reporting and different analyses that are required for each of the three agencies. And then finally, the results-oriented framework. Again, all say, yes, in principle, we are committed to that. But in the report that I read on this, progress toward the joint M&E system, monitoring and evaluation, is, quote, glacial, unquote. So the problems are certainly there. I'm very grateful that Ruth started out by pointing out to some of the successes in global health. We can't forget that. And I do believe in diplomacy. I've seen it in my own professional life, and I won't bore you with it, but I do believe in diplomacy, and I do believe in cooperative action. And in the particular area that I mentioned, I've raised 10 points where there are clear difficulties in a harmonized response or a harmonized assistance. There are a number of very practical, common initiatives. There is GIST, and this I'm still referring to the coordination between the World Bank, the Global Fund, and PEPFAR, the Global Implementation Support Team, which addresses implementation bottlenecks in countries, and all three participate in that initiative. GAMET, the Global AIDS Monitoring and Evaluation Team, UNAIDS organization, but Secretariat is here in Washington at the World Bank. All three participate. There is ASAP, the AIDS Strategy and Action Plans initiative, to come up with costed, strategic, prioritized national plans. The Global Fund and the World Bank participate, but PEPFAR does not. And then there's the Monitoring and Evaluation Reference Group, MERGE, in which all three participate. So, I didn't want to bore you with details, but I did want to give a sense of sort of reality of what these big problems mean on the ground and how organizations try to deal with them or don't deal with them, and the work that we still have ahead of us. I'll leave it there. Thank you.
What a great, that was just, I think we are, that's enormous thanks. It was a great setup for, I hope it's going to be a really rich discussion after our break, but I guess I'd invite you all to think about the fact that you've really gotten a chance to hear people talk about the history, the relatively long history of global health assistance, the complexity of thinking of it from a global perspective, a national donor perspective, and a sort of a receiving country perspective. And then within those countries, thinking about the challenges across both disease and the different kinds of investments that need to be made, and the complexity of how all those pieces fit together. And so I just can't imagine a better introduction than what we've gotten so far. So why don't we say 5 minutes? I've got on the computer 4:39, so why don't we say 4:45 we'll reconvene here, and then we'll start with questions. So thanks so much.
Oh, is that right? It looks like people. I know.
When I walked in, I well, the only reason I was asking was it occurred to me that they're all schools that I could have raised, but I didn't. Was it? Because I think of you as being more into, the work you did with Olivia and Wendy. Oh, I didn't. You were at ACF. Oh, okay. Okay. That's great. I mean, I think it's really the way to structure a career. You know, so you're always learning.
Everyone's attention. I think it's time to start the second segment here. I guess I would first invite if our panelists have any comments they want to make about each other's presentations. Otherwise, I think we'll just turn it to questions. Do you want to add further?
I just wanted to make one comment about the description of how much support goes for HIV/AIDS in Rwanda. Do you want to share with us what the prevalence of HIV/AIDS is in Rwanda?
About 3%. That's a good question. Any other? Why don't we start first with the students in the Colloquium? Go ahead.
I was wondering if I could ask you to do a little bit sort of, I guess, fortune telling in a way. I don't know how else better to sort of explain it. If the front runner in this election sort of ends up winning, what do you anticipate sort of? I apologize for this. What I lack in articulation, I make up in passion, but
No, that's fine.
What I do want to explain is sort of what do you
You're being
anticipate?
diplomatic.
Where do we see sort of the next battle in terms of on what committees on the Hill? Is this going to be, is the administration, do you think, going to be very much involved in this? I guess sort of asking, where is the action going to be, and where is we students who are interested in doing internships and sort of, where can we get plugged in if we want to help out in this?
I think we don't really fully know. We know that, to put some names to your question, Senator Obama in the lead now, and even members of the Republican punditry are saying there's no way he can lose, so we shall see. It's happened before. But, clearly he is very interested and committed to the role of the U.S. in a global community, deeply about health issues. So I suspect that he will be, receptive and interested. I think the reality, though, is that he's going to hit the ground with a couple of really tough issues that he has to grapple with that are going to take attention and resources, at least in the short term, from some of the work we might want to tee up. Obviously, the crisis is going to be first and foremost in terms of getting his team in place and making sure that programs and policies are there to try to keep the economic engine going and restore confidence in the economic situation. Related to that is, of course, energy and becoming more energy independent and reducing our overall consumption as well. And so I think there's going to be a big push, and that's going to have a global focus, but it's not going to be on our global health issues per se. And then bubbling up there are commitments, both political and idealistic commitments to healthcare reform, but that will have a predominantly domestic focus. So I think that there are several big issues, both in terms of human and dollar resources that may get a little bit of precedent on the global health concerns. But I think that they will be there. I hope that, and I forgot to mention military. I think that, finding a responsible way to move away from Iraq, but to intensify work being done in Afghanistan and Pakistan to try to stabilize those regions and reduce tensions. All of those are complicated, challenging, and hot-button issues that will be unfolding very rapidly. So I think, both to think about how to make sure that these issues are on both the president's desk, but also that people in key decision-making and leadership roles that won't be as caught up in those 100-day issues is going to be key. Obviously, there are big commitments through PEPFAR and some of the other programs to global health that will be continuing. The Senate and House of Representatives will have to actually make good on the PEPFAR commitments because it's now authorized but not appropriated. And then I think thinking about how to, there'll be a lot of emphasis on demonstrating value for investment, and I think that much of the work that several people at this table are doing and have been doing on really examining what works and what doesn't, and how best to use resources and balancing country needs with donor interests, et cetera, will all be decisions for a new administration, whomever that may be.
Yeah, maybe I can just jump in briefly, just building on that. I think if you look at the campaign statements and what's on the websites, there's no question that the Obama statements about global health are much more comprehensive and much more sort of well framed, honestly, from even an objective perspective than what McCain has said, which is a little more scattershot. And Obama, it's more or less a global health wish list, honestly. I mean, sort of what the global health community would ask. If you look historically, though, the times when development assistance and within that global health has done the best has been when there's been a Republican president and a Republican Congress. I know, I make a face about it too, but it's just the reality of it. And the times when development assistance has done worst and global health within it, yes, indeed, Democratic president and Democratic Congress. All you have to do is look at Bill Clinton. And so, we can come up with lots of political economy explanations for that. And I heard a sort of anecdote of an African health leader saying to somebody just a couple of weeks ago that he hoped Obama wouldn't win because he wouldn't have anything to prove to Africa. So I just want to sort of bring us back to the reality that we're living in. But aside from that, I would say that there are, if you're looking for sort of opportunities where there's going to be some interesting global health-related work going on, this may or may not be correct, but I think CDC is a great place to look at. They have a Washington office. I have no idea what their needs or ability to take on board other interns or anything is, but they do some really outstanding global health work in lots of different ways, and that's as close as you can get really core technical strength in public health. There are some really interesting issues coming up for the FDA, and the U.S.-based pharmaceutical industry, I think, is quite eager for the FDA to be better able to help position multinationals within a very broad global marketplace. So, for example, Big Pharma is really looking toward the emerging economies, Brazil, Russia, India, China, and even South Africa as the next frontier in terms of market growth. And the FDA has a role to play in helping to advance that. And so I think there's going to be some interesting work coming for the FDA. And third of three ideas is the Institute of Medicine, which has been charged. The Global Health Board at the Institute of Medicine has been charged in the PEPFAR reauthorization with undertaking a very large evaluation of PEPFAR. They're going to be staffing up. They're going to be looking for some free help and doing interesting work. So those are three ideas for you.
Thank you. Let me just follow up on that last point on PEPFAR, and that will certainly offer many opportunities for work. And I was interested to note during the height of the primary season, the Global AIDS Alliance presented its Stop AIDS plan, and both Senator Clinton and Senator Obama signed it. To my knowledge, Senator McCain did not. So it's a very detailed plan, and it's an organization that is not shy, let's say. And so it's. I think that Senator Obama will be held to the promises made in that by that signature.
And I'm not the expert in this. I've been thinking a bit about this issue of where the opportunities will be, and I think this will be true not just in global health assistance, but there's going to be an enormous number of domestic priorities that Senator Obama is going to, the people who support him if he wins will be seeking action, and frankly, for all the reasons that Dr. Hamburg outlined, he's going to have, whoever the next president is going to have enormous overarching challenges between the war and the economy. So I think I would just encourage you all to think along the lines that Ruth had outlined, that that the executive branch agencies that implement existing programs are going to be places where there'll be opportunities for creativity in an environment where the congressional and the White House agenda is going to be consumed as it needs to be with overarching, overwhelming in many ways challenges. That there'll be really important sets of decisions being made at an administrative and executive, at least the opportunity to be there for it. So just something, if you're thinking about where you want to go, that those are places where there could be opportunity. So let me get some questions here.
I have two general questions regarding the fight against AIDS. And my first question is the role of moral judgment. I sometimes hear people talking about they're not too happy about the idea of distributing condoms, or they're not too happy about the idea of abortions. And I understand in that their donations come from some people who care about those things. But on the other hand, I tend to feel that those moral judgments can distort the way the global community will tackle the AIDS, because for example, abstention will not work as effectively as distributing condoms, and those moral judgments can be a bit dangerous. And I just wonder to what extent those aspects can be dealt with so far, and what your opinion about that. And my second question is the role of local leadership. I hear a lot of stories about how the developed countries want to contribute to the AIDS epidemic in Africa, but I also feel that the AIDS epidemic will never be solved unless the local leadership will be involved. And of course, the local leaders will be busy tackling with other problems such as poverty or development or economic development. But in order to have a sustainable sustainable fight against AIDS, I think involving local leaders will be important. And I just wonder how those aspects dealt with.
Why don't I take the issue of abstinence and condoms? I mean, the rule in public health has always been use a tool which works for an intervention. And so, unfortunately for prevention of HIV/AIDS, we don't have all that many tools around, and we don't have such classical magic bullets. And condoms are one tool which can work for particular populations. And abstinence is another tool which can work for another part of the society. But one shouldn't really push one at the expense of the other one. That is at least my firm belief on that issue. It has created quite a bit of ill feelings in the international community, the position which has been articulated over the last years here. Sometimes it has been exaggerated. One has to say that as well. But to use, to influence, to basically develop shades of in which intervention technologies can be used is a very complicated process. Let's put it that way. Second issue of local leadership. Surely you need local leadership. People who, communities, political entities, have to own the issues around. If that doesn't happen, it's extraordinarily complicated to prevail. So,
you can just say one word, which is I think I absolutely agree 100% that effective public health programs have to use the evidence-based interventions that work, a whole range of them. And AIDS prevention is a particularly tricky issue, and not enough money and effort has gone into the research and creative innovation necessary to look for even more effective strategies. At the same time, the fact of the matter is that $15 billion for HIV/AIDS would never have been mobilized without the buy-in and advocacy and wholehearted support of the religious right and faith-based organizations. So it's extremely tension-filled, that's what I'll say, to say sort of, we want the money that you are able to mobilize, and we do not want the values that come with it. So even if I don't happen to share those values, I just think that it's important to put on the table that the political dynamic is such that if there weren't that sort of deal brokered with people who have those communities that have those values, there would never have been that amount of money made available. So just to sort of be the, I don't know, skunk at the picnic here.
Well, let me just also try to weave in one other level of analysis of the, really remarkable increase in interest in HIV, the resources that have come with it. And it's been partly, as we've said, that certain communities that had earlier tried to separate themselves from this issue and sort of been almost punitive about, those people's problems, have engaged and taken it on as a humanitarian issue. It's also been, I think, because the world of finance, multinational companies and local businesses have come to understand the impact of the disease on their business, on workforce, on social stability, etc. And so there's been a much more nuanced understanding of what this disease means at every level. And I think together of a much more sophisticated understanding about this as a problem that we can't just ignore. We can't just put it in a box. That it's going to continue to grow. It's going to continue to undermine all kinds of things that are important. To me, that has been part of the catalyst to this enormous new interest. I think that the more we can modify approaches as we go forward so that it's not just throwing money at the problem and counting how many people are taking drugs, but really looking at how to turn it into a sustainable program that addresses the most fundamental needs of people living in communities, building systems for care that go beyond just making sure they take this one particular medication, ought to be our common goal. And in doing that, I think we have to move beyond moral ideology and narrow, vested interest perspectives.
If I just can add one thought to that, we have bemoaned earlier the difficulties that arise with so many players in international health. But this is an area, in the area that you raised, is where we can turn that to an advantage. There are many other players who do not have these constraints that the next U.S. administration will have because of these requirements in the reauthorizing legislation. And so these other players, they will have no trouble supporting organizations that refuse to repudiate or stop their assistance to organizations that support prostitutes, or that condoms is not really a problem in the PEPFAR program, even though the White House puts a lot of emphasis on the A and B of ABC. In practice, my understanding is that the example that you raised is not really a problem. But on some of these other moral imperatives in the U.S. legislation, the World Bank, the Global Fund, and others can pick up the slack there. And it's an area where the global system works well, I think.
James? A lot of the material we read before we came in expressed the view that the United States needs to change its approach or attitude about intellectual property in global health. And I was wondering if you could comment about that.
Yeah, that's my hobby horse. Thank you for the question. And I couldn't agree with you more that this is a very important area that we need to look at. In the area of access to medicines, you can conceptually sort of divide the field in two sets of initiatives. Initiatives that deal with price in order to make medicines more affordable, and initiatives that deal with getting the right medicines, or getting the new medicines that are needed. And intellectual property rights very much relate to both of these concerns. There is no doubt that what has made possible this tremendous increase in treatment in developing countries, which has increased, I believe, tenfold in 2001 300,000 people were on treatment. In 2007, 3 million. That's a tenfold increase that could only have happened because the price of medicines came down by competition among generic manufacturers. It's not just the introduction of the first generic that drops the price a significant amount. But where you get the real significant price decreases is when there are several generic competitors in the market. And so this area of intellectual property rights and the way the U.S. has... Let me step back. You know the Doha Declaration on HIV/AIDS and on intellectual property rights and public health came out with some strong affirmation of the right of countries to use compulsory licensing to meet their import or production needs of generic medicines. The ink on that declaration was not yet dry when the U.S. embarked on a very ambitious and aggressive free trade agreements program. All of these agreements contain TRIPS plus provisions that make that reduce the possibility of compulsory licensing. And I need to go into the details now. There's no doubt that that program has been very detrimental both to the U.S. standing and respect in which people hold the U.S. And has been very detrimental and will be detrimental in the AIDS area because it will kick in and really start to have teeth for second and third line regimes. It didn't make an impact on first line AIDS treatment regimes because of the way the Indians wrote their law when they had to come into the fold in 2005 under the TRIPS agreement. But for second line regimes and certainly for third line regimes, there's no doubt that because of the TRIPS agreement and because of the TRIPS plus provisions in the U.S. Free trade agreements, that the access to generics is going to be limited. And it's going to be far more limited than we have known in the past. And those drugs that will be available will be more expensive. Does that answer your question?
I guess the follow-up is, what's the political chances of changing that attitude?
It's a very good question.
I'm assuming they went forward on this path because they were urged to by a domestic industry that has a lot of money and a lot of influence in Congress. And so realistically, is there a chance sort of, even if we have a new party in power?
It's a very good question. U.S. trade policy belongs to the executive branch, and although we'll see how it's going to play out because the trade authorization now has lapsed. Paragraph 4 of the Stop AIDS pledge of the Global AIDS Alliance specifically addresses this and seeks an assurance that generic drugs will be, or drugs will be available will continue to be available at more affordable prices for poor countries. And it uses quite explicit language. It actually uses rights language. It goes quite far in its thrust. To what extent the administration can reverse what has been done? Certainly under the free trade agreements, parties can always agree to interpret the agreement in a certain way or not to insist on full compliance with all the terms of the agreement. So there is a measure of administrative discretion here and executive discretion, which we'll probably hear more about in the near future.
Yeah, but just could say, in a very simplistic way, after the Euro round and when TRIPS came into being, the research-based pharmaceutical industry has dictated some terms. There's no question about that one. And the countries had to adjust. They revolted several times against it with the Doha round, etc. That is changing today. I think that is changing. I think TRIPS, TRIPS is better respected, and there are different political constellations which pressure the industrialized countries in a different direction, India, China, Brazil, etc. So I think the playing field is moving there.
I was just going to also add that I think when we think about some of the challenges before us with respect to intellectual property, it's not just about pharmaceuticals, it's also about biological entities and subcellular biological entities as well. I'm sure you're aware of the conflict with Indonesia about the sharing of avian flu samples and concerns about sharing them with the United States for multiple reasons, including the possibility that vaccine might be developed using that strain that then wouldn't be available in Indonesia. And I'm sure you're aware of issues around at what level of the genome can you patent something, and what does that mean in terms of access to emerging new drug treatments or understandings of disease risks and disease management. So it's a complicated set of issues. It's not getting any easier. It's generally spoken about in the context of pharmaceuticals, but it requires the kind of legal expertise being developed here to help us think through many other aspects of it as well.
Just quickly, I think a related area where there's potentially some fruitful work to be done, both in terms of research and then policy action, is around thinking of ways to separate out the rewards for innovation from the price of the product, because they're conflated right now, which is why one of the reasons why drugs are so expensive compared to the marginal cost of production. And so, that's all wrapped up in protecting, using IP to protect the monopoly during a period, when the manufacturer is trying to recoup the investment in R&D. So I think there are some interesting proposals out there for ways to separate, as I said, rewards for innovation from the price of the drug. There are others yet to be developed. So I think it's a related area that could be ripe for some interesting work.
We saw from the discussion and from the graph how HIV/AIDS has been a focus in the development assistance and resource allocation by donors. My question is, what, in your opinion, would be the best priorities, and how would you choose those priorities for donors?
Anyone want to jump at that?
Well, I think there has to be, I don't know the answer to that, honestly, because there's this complex interplay between what the priorities are, how much they resonate with those who are providing the money, and the amount of money you get. So I could come up with a lot of extremely unsexy priorities, which I could argue would be great for public health outcomes, and somebody would mobilize maybe $1.50 for it. So it's not easy to figure out what the right approach to priority setting is. So the only thing I'll say is that I think it's crucial to work on a stronger alignment of the international priorities and sort of direction, orientation of resources with what national governments and those who influence them at the country level want to see happen in their own countries. I think there's a real problem when international actors, essentially, because they have a lot of money, impose priorities.
Yeah, I want to follow up on that. It depends. The prioritization depends where you sit. If you sit in a health, in a village, you have certain priorities. If you sit, in Accra, you have certain priorities. You probably are better off. You have more opportunities, so you might be affected by chronic diseases, so you look at hospital systems. If you're in the ministry, you have to deal with these conflicting pressures which come from different angles. But nevertheless, one aspect which matters in all LDCs, at least as I know it, is the hospital system. Because the hospital system really determines the credibility of health services in the eye of the locals. we, coming from a public health perspective, might look at it quite differently. So there are these trade-offs which occur. If you then go into donor agencies, very different priorities come up. So as Ruth said, it's extraordinarily difficult to be prescriptive in the priorities. But I think it's a balance. It is a balance. When I worked in Indonesia, people always said, the problem with you in the Western world is that you see all things in dichotomy, in yes or no. We have several truths parallel to each other, and I think there's some value in that.
Parallel truths. I like that. Any other comments? Otherwise, let's open it up more broadly. But Michelle?
Dr. Hamburg, I have a question. You talked about the tension between security, like people who were in the hard securities and the fuzzy public health, and just what you thought, like how those tensions will play out at the next public health emergency and how the interaction will work.
Well, I think, is that there's a much deeper appreciation of the importance of public health. There's a much stronger working relationship between public health agencies and leadership around some of the kinds of disasters and crises that might require, mobilization. I think when it comes to willingness to defer certain kinds of decision making to public health leadership, it will always be the security types that will take the decision making chair. But I think it has been critically important to get more medical, scientific, and public health expertise at the decision-making table, both for planning and responses. And my guess is that the more experience in the field there is, the more people will recognize and defer. But it always has amazed me at how people working in the security area think that they can very quickly become experts in medicine and health, but they think that those of us that have trained in medicine or public health can't possibly understand the complexities of the world of security. So there's definitely an imbalance, and when push comes to shove, they always revert to classification and security clearances and make your life difficult by making it unapproachable. So they'll always have the upper hand, I fear.
Dr. Hamburg, speaking of classifications and security clearances, I can recall a time where there was a lot of public sharing of information, of bench work studies and research, even internationally. And I can recall coming into work when I worked in a laboratory post 9/11 and having to go through 3 security checkpoints and 3 padlocks just to get a sample of pestis out of the refrigerator. And it has become a frustrating environment for researchers to obtain samples that could advance public health from across borders, as well as the issue of biopiracy. Do you know of any empirical studies or observational studies that have shown this having an impact on research?
Really good studies to demonstrate it. There certainly is huge concern in the scientific community that some of the rules and regulations about the conduct of science, things like the select agent rule, things that have to do with export control measures, etc., are making it more difficult to do science in a laboratory, scaring people away from wanting to work in particularly high-level containment labs, and importantly, making it harder to collaborate with other labs, both within our country and around the world, and that our visa laws also are contributing to concerns that much science and scientific discussion is actually moving offshore because it's easier to hold conferences and it's easier to do research in other countries. To me, that's not the answer. The answer is that we need to really bring the scientific community into the discussions about how can ensure responsible oversight in a way that will not prevent important and meaningful research from going. It's a very difficult set of issues, and I don't think we've achieved it yet. Recent events around Bruce Ivins and the anthrax material that was obtained from Fort Detrick, I think has exacerbated also public and policymaker concern about, are we doing enough? And what we have to be careful about is that we don't respond to that by cracking down and putting more padlocks on laboratory doors, but really work with the scientific community to increase awareness about the potential risks, both of access to dangerous pathogens, but also the content of research. I mean, you can find amazing things in the open literature now that are basically blueprints for how to develop resistant strains of certain organisms and how to create new organisms de novo, etc. We haven't seen any of that translated into nefarious activities, but we know that there's interest and it is a real concern. So I think we have to develop a better international framework for these issues, and it's going to come from both leadership and self-governance within the scientific community and responsible legislation that can't just simply be on a national level. There has to be an international standard, and it's an area ripe for fresh input, new ideas, and lots of good legal minds.
I have one more question. So who has that? Julia,
I was just curious, with the spike, this dramatic spike in spending that you showed us on your graph, and I thought the cartoon you described was kind of shocking in its perspective. Is there a way to take some of these funds? Is there flexibility in the way global health programs are run to leverage some of the AIDS dollars in a way that overlaps effectively with dealt with from dealing with the AIDS crisis and treatment, and use it to kind of build infrastructure or leverage it so it could, down the road, serve in a way that same dollar could serve to help other global health problems. Same with malaria and, say, clean water and water infrastructure. Is there flexibility, or are these really rigidly drawn programs?
Let me try to answer that. The programs are somewhat rigidly drawn, but if you look at implementation, the old juxtaposition of vertical program and horizontal kind system strengthening actually, if you really look at it, doesn't exist. Naturally, even vertical control programs have always a systems effect, so that's part one. One should not underestimate that. They do something to strengthen the health systems. There's practically no activity which doesn't do that if you're in a vertical control program, to use that term. But more than that, in the last 3 or 4 years, there's a grumbling in the community, in the international health community, about this, the systems effect have become louder and louder. And so institutions like the Global Fund are now looking what could we do in terms of health system strengthening, and where could we package that one, in what way. So there is willingness to move in this direction. But it goes slow. And one of the problems is the often rigid requirements of some of the donors in terms of reporting what the outcomes are. Because the outcomes are often defined in disease terms, not in system strength terms. I think we need to work on that that dimension as relevant.
Yeah, maybe I could just to run for a train. I think what we see, harken back, agreeing with what was just said, and also harken back to my comment about the importance of aligning international programs and priorities with national government programs and priorities at that level. So where you see the resources really being used for these kind of systemic benefits is largely in countries where the government has a strong commitment to kind of harnessing and marshaling the resources that donors bring and saying, look, this is our plan. Thank you for your resources. If we can use your resources according to our plan, we welcome them. And if we can't, then thank you very much. Why don't you go to our neighbors? And that's happened in several countries. The most prominent one is Rwanda. And what you'll see is that when donors, and you'll hear this, I predict, you will hear this next week from Mark Dyball, when donors are pointing to countries in which their resources have brought about broader health system benefits, those are the countries in which the governments are strong in harnessing the donors, and Rwanda is at the top of that list.
Yeah, very quickly, just to make that concrete, what the previous two speakers have said, the new World Bank strategy on health, population, and nutrition, clearly evinces what has just been said, that the vertical program of HIV/AIDS is really being mainstreamed into health system strengthening. So it's a very of this trend.
Let me, with that comment, I think we owe the extraordinary panel a round of applause. So we do have a little reception out back. If anyone is able to stay with, I know you've got to go. We welcome you.
Oh my
That's awfully nice. That's awfully nice. Thank you.
So if you don't have it finished by the end of your train run.
Great. Well, enjoy your remarks.
Well, I actually have to go on my we're not going to do quite and I'm wondering, this book is it currently available at a well, let me write down.
I'm sorry, I figured Thank you, Ruth.
Thanks a lot.
It's interesting to me how everybody is really coming together now Yeah, you know, at one time it wasn't sexy. Now,
thank you.
People understand.
People are tired of fighting something that was useless.
Yeah.
As you said, on the operational level, the doctors should get the HIV training.